The views expressed on the Jerry Cahill CF podcast are that of Jerry Cahill and guests, and not necessarily those of the Boomer Esiason Foundation. Nothing on the Jerry Cahill CF podcast should be considered medical advice. Such advice can only be given by a physician who is experienced with cystic fibrosis. The Boomer Esiason Foundation, Jerry Cahill and guests cannot be held responsible for any damage which may result from using the information on this podcast without the permission of your medical doctor. You're listening to the Jerry Cahill CF podcast presented by the Boomer Esiason Foundation and jerrycahill.com.
Welcome to Jerry Cahill's Living, Breathing, Succeeding podcast series, The Path Forward with CF. This show, Lung Transplant Coordinator's Role Pre- and Post-Double Lung Transplant, was made possible through an educational program from Columbia University Irving Medical Center and an unrestricted educational grant from the Allergan Foundation to the Boomer Esiason Foundation. Today you'll meet my transplant coordinator, Maggie Carroll. Maggie Carroll has been a physician's assistant since 2009 and has been with Columbia's Lung Transplant Program since 2011. Maggie has the unique experience and knowledge of working on both the inpatient and outpatient side of the Lung Transplant Program.
My name is Maggie Carroll. I'm a physician assistant, and I'm the post-transplant lung coordinator for Dr. Argesway. I went to PA school in Pittsburgh, Pennsylvania. I graduated in 2009. And I initially started working at a hospital in the Bronx for the first 2 years of my career. And then I transitioned over to Columbia Presbyterian's Lung Transplant Program in 2011, and I've been here ever since. The hospital that I was originally at didn't have a lung transplant program, so like many other clinicians, I was never really exposed to it until I came here. Now that I'm here, it's hard to imagine me not being in lung transplant. A physician assistant is considered a mid-level practitioner. They go to a graduate program that's between 2 and 3 years, and they have the ability to prescribe medicine, order tests, interpret those tests, and all of this is done under the supervision of a physician. An RN goes to a different kind of schooling and is not able to prescribe medicines or interpret things. On the floor, the PAs function in a lot of different ways. For one, they're seeing the patients more than one time a day. They're stopping in the rooms, they're checking on patients. If patients aren't feeling well, the first person to respond to a sick patient is really the physician assistant. The transplant coordination process really starts with the OPO, which is the organ procurement officer from another hospital calling us, telling us that we have an offer for a lung transplant. The first thing we do is actually review the offer because not all offers are accepted. It depends on really the health of the lungs and how we feel about what these lungs look like and are they going to be appropriate for our recipient. Once we decide to accept the offer, I then call the possible recipient to consent them and explain what the offer is like. Once our team goes down to the donor OR, they actually do a bronchoscopy, which is when they insert a small scope into the lungs to be able to look on the inside of the lungs and really see what the quality looks like and if there's any signs of infection, secretions, or drainage. A dry run is when we approve the lungs, we think they look good, and we send our team to visualize them, and once we get there, they're just not the quality that we expect or think is good for our recipient, so then we decline them. I think the most important thing preparing for transplant is to educate yourself. There's a lot of different forums that you can do that. We, for example, at Columbia Presbyterian hold education seminars on a regular basis. The educational seminars are given by different people, the physician assistants, the coordinators, the physicians, the surgeons, and all of our multidisciplinary teams. So I think that's really the best way to prepare is to have the knowledge so that you're at least knowing what to expect after transplant. One of the most interesting things is people think right after transplant they're going to feel amazing, like a new person, and then they're going to go home right away. And it's a little bit more complicated than that. The first step is the Icu Care. Most patients are in the ICU for at least some given time after transplant. Once they're stable enough, they then move to the floor. And on the floor, really, it's about getting stronger, making sure that the lungs are working well, weaning you off the oxygen, and really educating you and getting you prepared for home. And then the third phase is the discharge, and whether that's to home or physical therapy or rehab, that's kind of the third and final step in preparing you to be out on your own in the home. Some of the biggest post-transplant complications that are specifically having to do with the lungs are usually infection and rejection. Infections can include things like viruses, bacteria, and even fungus because you're immunosuppressed. Some of the other complications post-transplant actually have nothing to do with the lungs. You can have kidney dysfunction, you can have blood clots, You can have different kinds of malignancies, and a lot of these have to do with the immunosuppressive drugs that we're giving you to help maintain the healthiness of the lungs. Immediately after transplant, once you're discharged, the first 3 months are probably the most difficult. For one, because you're getting used to your new organ, you're getting used to your new way of life, and there's a lot of monitoring that needs to be done. When you're at home, you're monitoring your vital signs, you're doing your lung function tests, and every week you're in clinic to see us to make sure everything is going smoothly and you're recovering well. After the first year is really one of your biggest milestones, because at that point you're not seeing us as frequently. You're feeling well, you're functioning back at home again, and you're really only coming to the transplant clinic every 3 months at that point, which is really different from those first 3 months when you're seeing us on a weekly basis. Post-transplant working can be kind of complicated. I think a lot of patients, depending on their age and what their prior job was, do go back to work. However, there are certain jobs that really concern us post-transplant because of the infectious risk. People who have worked in hospitals, like nurses, people who work in school districts with very small children. It's difficult because those are really environments that are high risk for infection because there's a lot of sick people. So I find that some people have to reconsider what they're going to do for work after transplant. The most important part about being ready for transplant is all about education. The more you know, the less scared you'll be, and the more educated your decision is to move forward with transplant. I think it's also important for caregivers to be educated as well, because they'll be the ones that are by that patient's side during the process and even after the process is over. Transplant is not a one-person job. It kind of takes an army, and that includes all of the caregivers and the physicians and the coordinator and everybody who's involved in the transplant program.